Wanumkarng International Hospital, I hope I pronounced that correctly. He's a recipient of multiple awards like the APAO Award, with multiple recognitions of his contributions, including Best Paper Award for Endoscopic PCR at AtEye.
Good afternoon, dear friends and colleagues, especially Dawn. It has been 21 years that I was here. So today is so honored and very happy. So this afternoon, I would like to share with you about my concept that I have used for the past 20 years. The content today is about how digital endoscopic DCR revolutionize the understanding. Sometimes they have the hidden anatomy and the hidden, and we can reveal the hidden bone and the concept that I have seen that I have realized that is so important for the surgery. On the beginning year, when I graduated for the fellowship, you can see the success rate is so low. It's only 81%. And we have done for a few years, it's being up about 88%. At that moment, I didn't recognize that the bone and the flap concept is so important. So we start to do gradually, started flap tutoring in 2006. But in those few years later, in 2008, the success rate a little bit high because we understanding more about the flap and the bone. So finally, we try to our best to get the success rate is nearly 100%. But I would say we cannot say 100% to every patient because sometimes even though we try to do the best, sometimes the healing, the scar tissue can overcome our success. So we start with the bone. For the bone, in the old day, we know only the two-dimension anatomy. The best way that we go to the anatomy, we put the pen light and we can see in the orbit, and we can see how thickness of the frontal fossa of the maxillary bone. So nowadays, in IT technology have been improved. We can use this application named Complete Anatomy. You can download from the App Store. It's very cheap, and you can see the relationship of the frontal fossa, the lacrimal bone, the nasal mucosa, and you can separate them. You can separate the frontal fossa out. See the relationship between the lacrimal sac, nasolacrimal groove, see every dimension of the bone. So you know the anatomy, you can see the lacrimal bone, how thick it is, the relationship between the lacrimal sac and the lacrimal bone, how thin, how thick it is, and you can see put the lacrimal ethmoid bone and see about all direction in 360. You can see actinic cell and the alginate prostate. Really good, and including the inferior concha, and in the relationship is very important for the beginner. If we can see this one before we starting the surgery, it's very important. To be familiar, you can use like this, and at home before the night of the surgery, you can use the application, remove the bone all on the lower 2/3, and then you can do this one at home at night time before the surgery in your bed. And you can start with the removal of the C-shaped flap. And this step is very important to try to preserve the nasal mucosa as much as possible because we have to leave the nasal mucosa. After that, we remove the upper 1/3 of the frontal fossa. This is a little bit more challenging because the upper 1/3 is very thick and sometimes it's narrowing, especially in the septal deviation. Some people use a chisel and the mallet, and some people use a dew and the lacrimal bone also. Sometimes we have to remove the lacrimal bone, and you can take the lacrimal sac out and see the relationship. Occasionally, we need to remove the actinic cell and the alginate prostate to optimize the exposure of the lacrimal sac. So, comparing to the DCR and endoscopic and external, I have seen the relationship. Most of the time, the external DCR, we can remove the bone very good. But underneath the medial canthal ligament, we cannot. So we have to remove the bone very good from the orbital side. But sometimes if you don't do the good approximation, we can get the failure. From the endoscope, we can remove the bone underneath the inferior medial canthal ligament. So to perform the appropriate endoscopic DCR, we need to understand how it fell. Because the most failure is because of the inadequate bony removal and the poor fab approximation. So let's start with the mechanism of the fail. So when you know the mechanism, you can do the conventional endoscopic DCR very good. This is the mechanism of the failure. The previous surgeon removed the inadequate bony removal, just remove only one lower two-thirds, but it damaged the nasal mucosa too much. You can see the gap area, you can see the bare bone. Encroaching, later that after the post-op, a couple months later, the scar tissue on the lid area come from the top and the down like the scarlactite and the scarlagmite phenomenon. After that, even though you put the silicone stent, if you put the stent long enough, you get lucky enough to get the sump syndrome. But if you put the stent too early, sometimes the maturation of the opening of the sump is not that good enough. So you got the total obstruction. This is the mechanism of the failure. If you put the approach from the external DCR and damage so much about the scar tissue, you can see in this area on the medial aspect of the lacrimal sac, on the red area is damaged so much, so the scar tissue encroaching. If you approach the revision on the external DCR is so different from the failure from the endoscopic DCR. This is going to show that when we remove the bone, we can remove by the endoscopic, you can remove on the upper one-third very well, and you can see, can export for the whole area of the medial aspect of the lacrimal sac, and differently from the approach from the external and the endoscopic DCR. Let's go to the flap concept. From the flap concept, we can use a digital for understanding. We remove the bone and we can see the relationship of the lacrimal sac and the nasal mucosa. You can remove the nasal mucosa in the first, and you can cut an eye shape or the head shape, depend on your preference. But I would say the eye shape is more favorite one. So when you remove the you need to open. I think cut a little bit, let the anterior flap a little bit bigger and try to make it marsupial as much as possible. And very important that you can see the area of the common canaliculus. So I start to do the flap suturing in 2006, and this is a suture. If you can use a suture number 6, S14 is a 90 degree. You can good, but you need to bend it a little bit. But the more practical one is a S22. S22 come with the 180 degree, but intranasally, the nasal cavity is so small, you need to bend a little bit. So can we classify about the 4 classification? I will start with the AP flap first. AP flap is a simple suturing. You just open with the eye shape, and with the suturing, you suture in the upper third first, and second you can suture in the lower part. And with my technique, I use two hand technique. I let my assistant lie down, touch me. Another assistant sit by another side, hold the camera super good in the fall of the nose, especially located in the infromedial of the fall. So that allow the space for the surgeon to use two-hand technique. We approach differently to the ENT guy. ENT use one hand and another hand to do the surgery on the lower of the endoscope. So we approach differently. If you have time, you can do the posterior flap suturing, but sometimes it's a little bit more difficult. Most of my practice, I do only the anterior flap suturing. That would be enough. And the superior flap suturing can do easier and can be applied for some condition, especially for the revision. I would focus on the isolated flap suturing. So I feel that flap suturing is good for the revision. I would divide to be superior flap suturing. In use, you can see on this condition is a failure from the another couple of 4-5 times for the failure. So the thick scar at the common. In this time, you can go to the common canaliculus, make the horizontal cut, and try to create the scar tissue in the superpart, and try to imitate the scar tissue like a superior flap, and try to lift it up, and suturing with the forehand technique on the right side, and try to suture the scar tissue that imitate like a pseudo flap. So that's really practical. And another one is the isolated anterior flap. This is a clinical of the SUM syndrome, and the scar tissue is a lot on the medial aspect of the lacrimal sac. You can open the nasal mucosa, and you can see the very thick bone in this part. If you do like conventional endoscopic DCR with flap suturing, I'm pretty sure that some high percent, more than 5%, 10%, this one can fail even though you can put the stent, because we did not forceful the anterior flap, rotate anteriorly maximally. By this way, put the gel foam, the kennel cord, that will help. So another one that I have used to optimize the result is intranasal continuous interlocking flap suturing. This one is going to be the benefit. You can try to do meticulously and slowly. It may a little bit difficult in the beginning. Please keep practice. And practice. When you do familiar return, you can do this one in a couple minutes. And this one can make the nasal mucosa and the lacrimal flap mucosa super approximation. So the benefit is less bleeding and well healed, no scar tissue, no granulation tissue. And that is the way that we can make the success rate nearly 100%. So by conclusion, flap and bone concept is very crucial, increasing the success rate of the endoscopic DCR to be nearly 100%. Removing the upper 1/3 is more difficult. It needs a high learning curve, and endoscopic DCR flap suturing could apply very good for the failed case. Thank you very much for your attention. This is a picture that I made for Don when his birthday in 2003. We still keep that. Thank you.